that's a result. That doesn't make clinical sense or scientific sense, and therefore the 50% is there for doctors to say, okay, I have to do better than that. I have to get down at least much more than a few percentage points, because people sometimes are near the cut-off level.
스케줄이 9시까지 때문에 조금 더 저는 궁금한 게 굉장히 많은데 질문하실 분 있으면은 종이에 써주시면은 뭐 아주 간단한 질문이라도 좀 제가 포장해서 질문 드릴 수 있으니까 질문 주시고요. So, what do you recommend actually in the practice in Scottish doctors? What do you recommend? So start with a high intensity, high dose statin, or just a combination of SMI and statin? What really like to recommend?
Well, I can tell you what's happening in Scotland. Up until the publication of Improve It, people were recommending 40 and 80 milligrams of atorvastatin. That's what we used in our ACS and people with chronic CHD. The problem that we have is that we were recommending that, the patients were being put on high-dose statin, and then 3 months later they went to see the family doctor, and the doctor would say, oh, your cholesterol is lower, you're cured, I'll take you off the high-dose statin and put you on to 20 milligrams of simvastatin. Very unhelpful. That's what really happens in Scotland. So now we have seen the use of combination therapy. It's not leapt up overnight, but the use of the combination of ezetimibe, something like 1040 with ezetimibe and simvastatin, is climbing quite clearly in our prescription use. We're still not getting enough people on high-intensity statins. There's still a lot of practice that people should be on there, but actually that's not even happening. So although the guidelines said high-intensity statin, the reality is that patients aren't being put on high-intensity statin except in the centres of excellence. So in my hospital in Glasgow, yes, they go on high-intensity statins, and now more of them are going on ezetimibe. And I think Adrian Brady's coming, and he's a practicing cardiologist, so you can ask him directly. But in most of the country, we're not even attempting to get to those guidelines. We're lazy. Or we're not lazy, but we're just not getting there. So I think there's still a lot of work to be done, and the EuroAspire study is typical of what's happening as well. So we need to get to go by those two mechanisms. So the short answer is, we weren't doing high intensity enough, but we are now using more ezetimibe. But it's not a big switch overnight. It's a slow increase as practice changes.
김상현 쌤은 어떠세요? 처음에 사실 하이인텐시티 스타틴 들어온 것 때문에 그래서 1년 반 동안 막 스트럭을 했는데 임프루브시 나와가지고 그 이후로 처음 스타트할 때 아토바스타틴 40mg 이렇게 스타트하세요? 아니면 아토바 10mg 더하기 에스테마이브 이렇게 스타트하세요?
저는 그전부터 이제 에제티마이브를 좀 썼던 편이라, 바이터를 썼던 편이라 크게 프랙티스가 달라지는 않았고요. 그리고 또 하이 인텐시티 스타틴 세라피를 AMI 빼고는 별로 안 했던 그런 사람이라서 아토바 80은 거의 안 썼고요. AMI 정도에 쓸까 말까 몇 명, 대부분은 모더링 인텐시티 스타틴을 썼기 때문에 크게 변화는 없는 것 같습니다.
처음부터 에스테마이브 컴비네이션 시작하는 적도 있어요?
그런 적도 있습니다. 이제 대개는 이제 스타틴을 메이저로 두고 쓰긴 하는데요. ACS는 되도록이면 스타틴 퍼스트 초이스고, 그렇지 않는 경우에는 스테이블인 경우에는 그렇게 됩니다.
사실 MSD에서 이제 아토제시 나오는데 이제 아토바스타틴 에스테마이브 컴비네이션인데, 사실은 김종석 어떠세요? 처음부터 아토바스타틴 에스테마이브 컴비네이션 쓴 적은 많이 없지 않나요? 아토바스타틴 쓰다가 에스테마이브 쓰고 몰라요?
네, 심바스타틴 콤비네이션 제제를 먼저 쓰게 되고, 아토로바 쓸 때는 아토로바 단독만 썼고, 아토로바 쓰면서 굳이 AJTB까지 같이 쓰지는 않았었고요.
그걸 참 MST에서 증명하기 좀 쉽지 않을 것 같은데, 하여튼 이론적으로 굉장히 좋은 컴비네이션인데 이제 프랙티스가 잘 질문이 또 2개 들어왔는데요. Yeah, two questions, very about biochemistry.
Oh, yeah.
Do you believe that statin reduces with the oxidation of LDL?
It reduces the oxidation potential of LDL. In other words, by reducing LDL subfractions, particularly small dense LDL, the LDL becomes protected against oxidation. I'll answer a little technically. LDL has a residence time in the bloodstream of about 3 days. So if I make an LDL molecule, it lasts for 3 days, and it will get oxidized during that time and damaged because it's around for a long time. But if I go on a statin, the residence time goes down to 1.5 or 2 days. So it doesn't get as old before it's cleared by the liver. So there is less potential for the LDL to be oxidized. So if you take LDL from somebody before statin and then on a statin and measure oxidation, you can see differences. So the drug itself doesn't stop oxidation, but it changes the LDL in a way that prevents it being oxidized.
So what's the role of Lp(a)?
Lp(a).
We're not talking much about the
No, Lp(a). We don't have good drugs yet for Lp(a). Lp(a) was very popular in the 70s and 80s, then it went away, and now it's popular again because the genetic studies say that Lp(a) is strongly associated with risk if you have an Lp(a) above 30 milligrams per deciliter. So in your patients, if you say somebody has coronary disease, see somebody with coronary disease with a low LDL cholesterol, you should measure Lp(a) to see if they've got a very high Lp(a). Now, we don't know what to do about that yet. There are drugs that have been developed that interfere with Lp(a) production, and there was papers in the New England Journal on that recently. But also the CETP inhibitors, anacetrapib lowers Lp(a) about 25%. PCSK9 inhibitors lower Lp(a) about 25–30%.
Statin does not?
Sorry?
Statin does not reduce it.
Statin doesn't reduce it. Statin reduces, if you give a statin, what we used to say is, if Lp(a) is high, then that increases risk, so reduce LDL further. So if somebody's moderate risk, but with a high Lp(a), treat them as though they're at high risk and be more aggressive in LDL lowering, because the risk comes from Lp(a) and the LDL, so at least you're lowering the LDL down. But maybe in 3, 4, 5 years' time, we will have drugs to lower Lp(a), and we may be able to do something directly. But that will be a small number of patients. Not everybody has a big Lp(a), but it's important as a risk factor now.
So next question is about the increase of diabetic risk in high-dose, high-intensity statin. Actually, this question is going to Dr. Kim.
Good.
Specifically. So I read in English, but you can hear the question. So, in the patient with the possible diabetes, impaired glucose tolerance, maybe a combination therapy can be a first indication rather than the high-intensity single statin therapy. What do you think?
네, 지금까지로는 그 스타틴 하이인텐시티 쓰는 것보다는 하이인텐시티 안 쓴 분이 당뇨 발생 위험도 11% 정도 차이가 나기 때문에 하이인텐시티를 피할 수 있으면 좋죠. 그래서 하이인텐시티를 피하면서 똑같은 정도로 LDL 낮추려면 컨비네이션 세라피 하는 게, 에제티멀 컨비네이션 세라피 하는 게 당뇨 발생 위험도를 낮추고 LDL을 비슷하게 낮추는 게 장점입니다. 그런데 이제 그런 정도의 환자분을 잘 선택을 하셔야죠. 그래서 현재 가이드라인은 당뇨 발생 위험도를 걱정해서 스타틴 쓰는 것을 두려워하지 말라고 되어 있기 때문에 그런 점은 이제 그게 적정한 환자분, 예를 들면 프라이머리 프리벤션이면서 그다음에 당뇨 발생의 리스크 팩터를 가지고 있는 사람, 즉 TG가 높다거나 오비시티가 있다거나 메타보릭 신드롬이 있거나 TG가 임페어드 패스팅 글루코즈가 있는 그런 사람한테 이제 주로 그런 위주로 어프로치를 하는 게 도움이 될 것 같습니다. 롱텀하게 써야 되니까 라이프타임 리스크를 라이프타임 트리트먼트로 하려면 그런 것도 생각을 해야 되죠.
what do you think? The first indication of the combination therapy, maybe the patient with some impaired glucose tolerance is a good idea?
I think that's a good idea. We already have the information. I mean, Dr. Kim presented it because the question was, what does ezetimibe do to glucose control? And now there's several papers in the literature suggesting that it actually is neutral or slightly better. There's a suggestion from animal models that it lowers liver fat and that improves insulin resistance centrally. So it looks as though the combination is going to be a better option in people with pre-diabetes, insulin resistance, than actually giving them 20 years of therapy with high-dose statin. Because the risk of, and I said this previously and it was reiterated by my colleague, the risk that we know over 5 years, we don't know what the risk is over 20 years. And it's one of these things that now we have an option, we should be looking at that. And it's useful. I don't see any downside to taking that option in terms of the benefit to the patient.
이게 사실 제 생각도 이게 당뇨를 증가시키는 효과가 아웃컴에 영향을 안 줬지만 이게 스타트가 5년짜리 스타트인데 당뇨는 이벤트 생기려면 한 20년 걸리거든요. 사실 여전히 저는 좀 당뇨 리스크 있는 거를 좀 걱정을 하고 좀 올라가면은 에스티마이드 컨비네이션 빨리 바꾸는 게 So second question is that the ezetimibe reduces the absorption of cholesterol and the possible effect on the weight loss. Is that true? Is the question.
Yes, there is no effect on me. No, it's not going to make me deny it. I think if it produced weight loss, I think MSD would be selling it by the bucket load. I'm afraid you normally excrete about a gram of cholesterol in the feces, and it goes up to 1.5 grams or something like that. So you're not losing very much fat. You actually are just specifically losing the cholesterol that's going through the enterohepatic circulation.
Actually, in the slide presentation, the ezetimibe may reduce the HbA1c, the risk of diabetes. Is that true? Or if it is true, what's the mechanism?
정확한 메커니즘은 아직 뭐 크게 밝혀지는 건 없고요. 지금 뭐 전번에 보니까 경북 삼성병원에 저기 박재령 쌤이 논문 쓰신 게 있는데 에zetimibe를 투여하면은 DPP4 이니비터 대사와 또 연관이 있고 뭐 글루코스 메타볼을 개선한다 그랬는데 애니멀 스터디에서 좀 보인 것 같은데 아직까지 뭐랄까 기전은 잘 모르고요. 그다음에 패티리버에서 약간 도움이 된다고 그러는데 그런 기전이 있을 거라고 생각은 되는데 헤파토사이트에서 뭐 에피세널이 작용하는 것을 액션을 줄 거다라는 어떤 액션을 할 텐데 잘 모르겠어요. 근데 지금 뭐 줄인다기보다는 인슐린 리퀘어먼트를 좀 줄인다 이런 것은 있습니다. 왜냐하면 그는 메커니즘이 증명이 돼 있는데요. 인슐린 리지스턴스가 생기면 엔테로사이트나 헤파토사이트에서 콜레스테롤 업소션이 증가되거든요. 근데 그런 거에 관련하는 그런 쥔들에 좀 더 좋은 영향을 준다 이런 데이터들이 있습니다.
Actually, this question was not for him, for you. Do you believe that the ezetimibe reduces diabetes? That is that there is some mechanism, some animal data to support it?
I don't think there's a lot of evidence that ezetimibe lowers body weight.
Diabetes.
In terms of diabetes, I personally would want to wait for much bigger studies before I took that. I think it's sufficient at the moment to know it doesn't have a statin-like effect on new diabetes, on insulin resistance, because you can see clear differences. If you put somebody on a high dose of statin, then insulin resistance worsens, and there's just publications on that, and that's not present for ezetimibe. But in terms of reducing